Hello there, let's look at some medical questions.
So if you're preparing for your MBChB, the neuro section of the exam, today's video is going to be hopefully incredibly high yield. And then we're going to work through 20 past paper style multiple choice questions that I got from some more senior students. And the questions are going to be on the neuro part of raised intracranial pressure and herniation syndromes. Now, here's the important thing. So don't just memorize the answers, because as you know, medical school examiners rarely ask the exact same question twice, but they absolutely test the same concept in different ways. So for every question today, I think what we'll do is we can explain why the correct answer is correct, why the other options are incorrect, and the clinical applications of it, so that it will be easy to answer future similar questions. So what you can do is, before we reveal the answer, you can just pause the video and try and get it yourself, and then you can see whether or not it's correct. Okay, so question 1. So for question 1, a 23-year-old woman presents with headache, I can't pronounce this very nicely, but transient visual obscurations and pulsatile tinnitus. So the MRI imaging, so the magnetic resonance imaging, is normal. The lumbar puncture demonstrates an elevated opening pressure, and then it asks what is the most likely diagnosis. So you can see the options that are available, and then the correct answer is C, idiopathic intracranial hypertension. So why is it C? So whenever you see a young woman, you see headache, you see visual symptoms, you see normal brain imaging, but an elevated lumbar puncture opening pressure, your mind should immediately think idiopathic intracranial hypertension. And the reason why is because you'll notice that there's no mass lesion and no hydrocephalus mentioned, yet the intracranial pressure is elevated. So this condition is classically associated with obesity in women of childbearing age. So one important complication is permanent visual loss if it isn't treated. So then here's an exam pro tip, or an example if you like. So young overweight woman plus raised opening pressure equals idiopathic intracranial hypertension. So there, the answer is C. So let's see what question 2 asks us. So according to question 2 says, according to the, you can pronounce that nicely, Monro-Kellie, I think, doctrine, and cranial cavity. The cranial cavity contains brain tissue, blood, and all those options, and then the correct answer would be A, so CSF, so cerebrospinal fluid. This is one of the most important concepts in neuro, and the reason for this is because the skull is a rigid box. So inside that box there are only 3 major components. So there would be brain tissue, blood, and cerebrospinal fluid. So the total volume remains essentially constant. If one component increases, another must decrease. So initially the body compensates by moving cerebrospinal fluid into the spinal canal and reducing venous blood pressure. And once these mechanisms fail, intracranial pressure rises dramatically. So remember this concept because it explains almost every cause of raised ICP. Okay, let's look at question 3. So question 3, which is an early manifestation of raised intracranial pressure? And then you can pause now, and now once you unpause, the correct answer will be headache worse in the morning. And the reason why is because morning headaches occur because carbon dioxide rises slightly overnight while laying flat, and this increases cerebral blood flow and intracranial pressure. And early symptoms of this include headache, nausea, vomiting, and things of that nature. So what are the late findings? So the late findings would include brainstem compression and abnormal posturing and respiratory failure. And exam tip here would be, whenever an examiner asks for the early feature, just think headache. Okay, let's look at question 4. So question 4 says a patient with severe traumatic brain injury develops hypertension, bradycardia, and irregular respiration. So here is a patient, they develop hypertension, they develop bradycardia and irregular respiration. So what is this called? The correct answer would be Cushing Triad. So why is it Cushing Triad? Because this is not an early sign. This is a late sign of dangerously raised intracranial pressure and impending brain herniation. So if you see Cushing Triad in an exam, think emergency. Now let's look at question 5. So question 5 is, what is the most common cause of uncal herniation? And the correct answer would be temporal lobe mass lesion. So why is it that? The reason why it's that is because as the temporal lobe expands, the uncus is pushed through the tentorial notch, and this compresses nearby structures, particularly cranial nerve 3. That's why the next question follows perfectly. So for the next question, it says a patient develops a dilated non-reactive pupil after a temporal epidural hematoma. Yeah, a lot of nice words there that we learned about. And the question that follows is, which nerve is most likely compressed? So what nerve do you think it is? Okay, so the nerve that it is the oculomotor nerve or cranial nerve 3. So why is it that? Because the reason it's that is because compression causes ipsilateral, my pronunciation's not the best, but ipsilateral dilated pupil. You can correct my pronunciation, please. Loss of parasympathetic function and impaired eye movements. And one of the most classical neurological examination findings is, remember, Uncal Herniation equals cranial nerve 3 compression, which equals blown pupil. Okay, let's look at question 7. So for question 7, which herniation pushes the cingulate gyrus beneath the falx cerebri? And the correct answer will be, my pronunciation not being so good, will be Subfalcine herniation or Transfalcine herniation. And the reason for this is because the cingulate gyrus moves beneath the falx and may compress the anterior cerebral artery. And for that reason, that brings us straight into question 8. I like this one. So question 8 says, compression of which artery may occur in subfalcine herniation? And the correct answer is anterior. It will be anterior cerebral artery. So the ACA infarction mainly affects the lower limb. So if the stem describes subfalcine herniation followed by leg weakness, think ACA compression. Let's look at question 9. So question 9, a patient with uncal herniation develops a contralateral homonymous hemianopia. Okay, this is due to the compression of and then the correct answer will be compression of the posterior cerebral artery. And then why is it that? The answer is that because the PCA supplies the occipital lobe, and damage here produces visual field defects. Let's look at question 10 real quickly. So hydrocephalus raises ICP because, and the correct answer would be because CSF accumulates within the ventricles. And the reason for this is because whether due to obstruction, impaired absorption, or excessive production, ventricular enlargement increases intracranial volume and also pressure. Question question 11 to 20, I'm going to do a rapid fire here. So let's speed things up. So question 11, for question 11, so papilloedema is the classic sign of chronic raised ICP. Okay, question 12. Okay, those are the options. So question 12, a cerebral. I'm just giving the quick fire here so we can get through it and get through the next past paper questions. So for question 12, a cerebral abscess raises ICP. You can pause and have a look at the questions and try to guess it yourself, and then continue. So a cerebral abscess raises ICP because it behaves as a space occupying lesion with surrounding vasogenetic edema. And then for question 13, the brain tumors classically produce vasogenetic edema because they disrupt the blood-brain barrier. And then question 14. For question 14, the posterior fossa tumors are dangerous because they may cause tonsillar herniation. And for question 15, tonsillar herniation compresses the medulla, affecting the respiratory and cardiovascular centers. This is rapidly life-threatening. And question 16, following head trauma, following head trauma, one of the most common causes of acutely raised ICP is an epidural hematoma. Question 16. So the central transtentorial herniation involves downward displacement of the diencephalon and midbrain. And question 18. Patients with central herniation often show progressive deterioration in consciousness due to compression of the reticular activating system. Question 19. Before ICP rises significantly, the body's first compensation is displacement of CSF into the spinal canal. So CSF is, as we know, cerebrospinal fluid, into the spinal canal together with reduced venous blood volume. This comes directly from the Monro-Kellie Doctrine. And then question 20. So for question 20, this is our last question. Which statement is correct? So the statement that is correct here is the uncal herniation commonly causes an apsilateral dilated pupil, and this is one of the highest yield facts in all of neuro. So for our final high yield review of what we learned today, before your exam, memorize these. The Monro-Kellie Doctrine, so brain, blood, CSF, and constant total volume. Causes of raised ICP, brain tumor, trauma, hydrocephalus, abscess, meningitis, intracranial hemorrhage, idiopathic intracranial hypertension, and cerebral edema. So early signs: morning headache, vomiting, papilloedema, cranial nerve 6 palsy, reduced consciousness. And late signs: Cushing Triad, brainstem compression, herniation, respiratory failure, and Herniation Syndromes. Subfalcine, so there will be cingulate gyrus beneath falx, ACA compression, and leg weakness. Uncal will be temporal lobe, cranial nerve 3 compression, ipsilateral blown pupil, and also PCA compression may cause visual field defects. And for central, it will be downward movement on diencephalon and midbrain, progressive decline in consciousness. And for tonsillar, it will be cerebellar tonsils through the foramen magnum, medullary compression, cardiorespiratory arrest. So if you found this video helpful, make sure to, I'm gonna do whatever random outro here just to make it fun. So if you found this video helpful, make sure to like the video, subscribe to the channel, and share it with all your classmates who are prepping for neuro. And good luck with the test that is hopefully on Thursday. And then you can comment below how many questions you got correct, because that will help the algorithm. And then also subscribe and share this, because that will also help the algorithm, and then more people can get helped, and then more people can help other people. And that's how it works. And thank you for watching this video because I hope it helped you, then you can help other people when you're a doctor. Bye bye.